A very warm welcome to all my subscribers and viewers. And if you haven't subscribed yet, please subscribe ASAP to get fresh content and tips, and so that we can study together and together we treat our patients. So today I am studying and sharing with you guys the most learned topic, minimal change disease, nephrotic syndrome in nephrology. I shall focus on some points that you might not be aware, so keep on watching. Minimal change disease. Now, as you all are known to this topic, minimal change disease is a topic of pediatrics, like not pediatrics in general, but some age groups allowing up to 15, 18 years of the age group. So this is the category where the patients are teenagers or say 10 years or say 8 years, and they come up with that of swelling in the limbs and frothy urine and swelling in the whole of the body. Generalized anasarca is seen. So let's just give a brief introduction and what is the minimal change disease, and we are also going to look on some topics or certain points where I have collected from specialized books, and this is a topic where you learn so much after reading multiple times and going in depth of this topic. So I shall be sharing with you guys my notes. So yeah, so 90% of the MCD occurs in the children and 10% MCD in the adults. So adults, what is the most important thing? FSGS. We all are aware of that. Focal segmental glomerulonephrosis. Now, MCD. What are the causes of the MCD? So one of the thing is the NSAIDs, that is the interferon and the interferon alpha. These are the drugs. Okay. Coming to the drugs and metals, and like that of lithium. One of the thing is lithium. Then we also have post-vaccination. There is a Hodgkin's lymphoma, okay, CLL, okay, mycosis fungoides. So these can be causes, right? You might be wondering why I have made certain points like this, so that I can make them, I can just hold on to the memory for a longer period of time. This is my technique, so that I jot down the points and I can remember these points in the exam. Okay, so then there would be effacement of the food process as well. So what happens is, when it comes to the pathogenesis, there are certain theories. One of the theory that what is written is the T cell responses or the expression of CD80 or the CD40 ligand, and which alters the capillary charge and podocyte integrity. Okay, so there is also increase in the angiopoietin like peptide 4. Okay. Another thing is the loss of anionic charge that is causing a proteinuria. So we have seen that MCD, we do not have hypertension as such, but now there are certain articles and there are certain study which is saying hypertension is also seen in case of minimal change disease. 30% of the children have hypertension, and 50% of the in 50% of the adults we can see hypertension. Remember, another thing that is there is the microscopic hematuria. Okay, that can be seen in 20% of the children and 33% of the adults. Okay, one thing is there will be a selective proteinuria. Okay, so biopsy, the biopsy will be done, when will it be done now? So only when the children are non-steroid responders, and the children, only then the biopsy is done. So this is a quite benign pathology in children, whereas in adults we have to go with the biopsy. So there is a timeline where you have to go with the biopsy. That was not very clear, but now it is very clear what is the timeline. I shall be discussing it. So and now coming to that of a remission, how do we see there is a remission after giving the steroids? That is less than 0.2 milligram per 24 hours of the proteinuria. So there could be a complete remission. Now, frequent relapses. What is frequent relapses? 2 or more relapses in 1 month, or 3 or more relapses in 1 year. Okay, remember that. Adults are not considered steroid resistant until 4 months of therapy. Now, this is the timeline, that is 4 months we can go with the biopsy, right? So now, so when we can consider them as a steroid resistant. Okay, so now when it comes to that adults, the remission should be done by 20 to 24 weeks. Okay, and in children it would be done by 8 weeks. So it is preferably very easy for the children to undergo remission. And in the adults, if there is a steroid resistance, we should be considering steroid resistance in such patients when it is more than that of the 4-month patient has not been responding to the steroids in the adult, and in a child when it is more than 4 weeks of full dose of the steroid, then it is considered steroid resistance. So what do? We have to repeat the biopsy, and most of the time it has been seen that after repeating the biopsy, the patient is actually a FSGS, and this is something which is a really dangerous, because this is the genetic form which is of the FSGS, which is very resistant to any kind of treatment, any kind of treatment. Okay, now rapid tapering of the steroids can go with the relapses. This is true with any of the autoimmune diseases or any of the diseases, right? Okay, so now when it comes to that of the treatment part, we give prednisolone, right? So how do we give? We have 2 milligram per kg per day in a trial for 6 weeks. Followed by that, we give 6 weeks alternate. Okay, dose. So remember this. This is very important. 2 milligram per kg per day. Okay, whereas in adults it is still 1 milligram per kg per day. Okay. Now, frequent relapses, what do? We give cyclophosphamide, chlorambucil, mycophenolate. So this is the steroid dependence, we say. And also in the steroid resistance, also we give cyclosporin and tacrolimus. Okay. Now, remember, certain points I have just added after reading certain other textbooks. So they have been added in the last or in somewhere in the middle. Okay, so there are certain points you will find that they have been repeated, right? This is because there are certain amendments have been done in the treatment policies or in the depending upon the textbook, whatever I have read. So I will be telling you that this is authentic, and this can come in the MCQ, and this was one of the MCQ like that. Okay, now. So what do? We, along with the treatment, you have to go with the protein that is 0.8 to 1 gram per kg per day. Then there could be salt restrictions as well. Okay, less than 2 gram per day. Two-thirds of the relapses occur in the LRDI and the URDI. Now, okay, now what is we have read in the Harrison is, and if there is a RBC in the urine, if there is increase in the creatinine, and if there is an hypertension, it is not an MCD. Okay, whereas nephrology textbooks say that there could be RBC in urine, that is, there could be hematuria, there could be hypertension in the MCD. So this is a controversial topic, but yet then if you are giving any SS exam, okay, super specialty exam, then people do not only refer Harrison. Okay, it is not like that. You have to read the nephrology textbooks also. But if you are giving a PG exam, or say you are giving a NEET exam, then it's fine to just make you understand that yes, hypertension can we could say that hypertension is not a part of MCD, hematuria is not a part of MCD. Okay, so how do we start? We start in a child. We start with prednisolone 2 gram per kg per day for 6 weeks. Same alternate day dose we can give for 6 weeks, and then taper of the dose in the child. Okay, and in the adult it is 1 gram per kg per day. Okay. Okay, so there is hypoalbuminemia. Okay, we are aware of that, which has a strong association with thrombosis. Now, this is very important because this can be also seen in case of membranous nephropathy. If you have any MCQ saying that thrombosis, which would be more common in FGS, MCD, and membranous, tick mark membranous because it is more common. And here we have to give with the DVT prophylaxis also in such patients. Okay, steroid resistance MCD. So we go with the biopsy, FGS, genetic form. There is no response to any of the immunosuppression. It is a very, very bad disease, as I have already said, right? Okay, so this was the number. This is one of the stats that I have read, that 25% they can have no relapse, 25% they can go into infrequent relapses, and then 50% they can go with frequent relapses. Just the stats, okay? When I'm talking about the steroid dependence, that means within the 14 days of stopping of the steroid, or while in the tapering dose of the steroid, the patient have gone into relapse. Okay, so that is a steroid dependent. And again, we have to go with the cyclosporin tacrolimus. If it is not responding, the last resort is obviously rituximab. So you can just remember that if it is a dependence, if it is a relapser, if it is any of the steroid resistance cases, you have to go with cyclophosphamide, tacrolimus, cyclosporin. Okay, these are the three drugs which we are using. Now, if the patient of a nephrotic, that is a child, comes and patient is started on the steroids, if there is no response to the steroids after say 4 weeks, okay, we perform a biopsy, and it is 4 months in case of the adult. Okay, we perform a biopsy. Okay, so if it is an FAGS, see whether it is a genetic form, autosomal recessive, autosomal dominant form. Autosomal recessive, we have a Podosin mutation, and autosomal dominant, we have alpha-actinin 4 and TRPC6 mutation. When it comes to, if it is on the biopsy, we have performed the second biopsy. Instead, it is an MCD. It is actually a resistant case now. We have to go with the cyclosporin and tacrolimus. We have option over here. We do not have any option over here. After the remission, say in the MCD, again a patient has the MCD episode. Okay, so what do? We again give steroids. Okay, provided the patient has already been in remission. When we talk about frequent relapses, I have already discussed more than 2 in 6 months, more than 3 in 1 year, and we have to go with cyclosporin, tacrolimus, calcineurin inhibitors, and cyclophosphamide. In a steroid dependent, again, we can go with calcineurin inhibitors. Take care. If there is nothing is working, mycophenolate mofetil as well as rituximab can be used. If it is an adult patient is started on the steroid, after 6 weeks there is no response, steroid resistant nephrotic, we have to go with a biopsy. Okay, so after 6 weeks, okay, there it was a 4 weeks. Okay, now there are certain books it is given 20 to 24 weeks, but recently I have found out that it should be 6 weeks. After 6 weeks there's no response, then we go with the biopsy, because it is really difficult for us to stay up to 20 to 24 weeks. I can understand that, because if there is some other pathology, we have to address to that. Okay. And now, procoagulant factors in the nephrotic syndrome. So this is a list of the certain procoagulant factors which are contributing to that of the thrombosis. Now it could be increase in the blood viscosity, there could be a hemoconcentration, there could be increase in the plasma fibrinogen levels, there is increase in the intravascular fibrin formation, increase in the alpha 2 macroglobulin as well. Factors like 9, 10 and 12, they are decreased, okay, and factors like 2, 5, 7, 8, 10, 13, they are increased. So decrease in alpha antitrypsin is there, decrease in fibrinogen activity is there, decrease in plasma plasminogen, decrease in antithrombin 3, protein S is decreased, there is thrombocytosis. Remember all of these, because this is MCQ. You have no other alternative, you have to remember this. So remember, there is a practice of giving Lasix, okay, a diuretic, to these patients. Now, will it work? That is a question. There is an underfill theory. That means in a nephrotic syndrome, there is an intravascular edema. Okay, where does the Lasix work? It works on the extravascular edema. Why are we giving it? God only knows. Okay, so it is an intravascular edema, so Lasix won't help these patients. Okay, so remember that. So now what is the pentad? We can say that there is a proteinuria in the adult which is more than 3.5 gram per day, and in a child it is more than 4 gram per day. Hypoalbuminemia could be there, that is less than 3.5 gram per deciliter in case of nephrotic syndrome. There would be an edema, hypercholesterolemia, and there would be a lipiduria. Okay, so calcium channel blockers, dihydropyridines, they can worsen the proteinuria. That's why in general also, for decreasing the proteinuria, we have certain drugs like ACE inhibitors, ARBs, mineral receptor antagonists, beta blockers, alpha blockers, diuretics, and non-dihydropyridines, that is calcium channel blockers. Okay. Okay, so this was the for the proteinuria. Okay, you can use either of any of this. We can go with enalapril, ramipril. Generally, these are used. Okay, Telma, we can go with that. So if the patient of a nephrotic syndrome is on the treatment, what do I have to do? Or daily we have to go with the dipstick test. Daily we have to go with the serum albumin. We have to check them, and daily weight should be checked. Okay. There is an entity podocytopathy. Okay, this we have studied in during the MBBS only. Podocytopathies. Podocytopenia, that means decrease in the number. There is no podocytopenia in MCD. When it comes to the podocytopenia, we have to think of FAGS and membranous nephropathy. Okay, so this is the podocytopenia. Okay, FAGS and membranous nephropathy. Okay, so now these are also nephrotic only, but the thing is, this will be seen in adults and this will be seen in case of the elderly population. Okay, So this was all for today. I hope you have enjoyed the video. You have understood the content also, and please do comment on the topic, whatever the topics you need or whatever you have not understood, so that I can make much more better topic or any other topic that I have not yet made. So please do comment and please subscribe. Thank you for watching.